Good morning, everyone, and welcome to another session of Medical Microbites. Today, we will explore one of the most important challenges in modern tuberculosis management drug resistance in Mycobacterium tuberculosis. Let's begin by briefly revisiting the pathogenesis of tuberculosis because understanding host pathogen interaction is essential to understanding how drug resistance emerges. In the previous slide, we discussed how inhaled Mycobacterium tuberculosis reaches the alveoli, survives within alveolar macrophages, and eventually triggers a robust Th1 mediated cell mediated immune response. We also saw that the final outcome of this immune response is the formation of a granuloma. Now, the obvious question is what exactly is a granuloma? Why does the body deliberately build such a highly organized structure around the bacilli? Is granuloma protective or does it actually help the organism survive? Let us understand these fascinating host pathogen interaction. Structure of a tuberculous granuloma. A tuberculous granuloma is not simply a collection of inflammatory cells. It is a highly organized immunological structure created by the host to contain but not necessarily eradicate Mycobacterium tuberculosis. Central caseous necrosis. At the center lies the caseous necrosis, a soft cheese like acellular material formed because activated macrophages release lysosomal enzymes, reactive oxygen species, and inflammatory mediators. The hypoxic acidic environment limits bacterial replication but does not completely sterilize the lesion. Infected macrophages. Surrounding the necrotic center are infected macrophages containing viable bacilli. These macrophages represent the primary intracellular niche where MTB survives by inhibiting phagolysosome fusion, resisting oxidative killing, and manipulating the host metabolism. Now, next is the epithelioid cells. Activated macrophages undergo morphological transformation into epithelioid cells. These cells have abundant eosinophilic cytoplasm and reduced phagocytic activity but increased secretory function. Their principal role is cytokine production and maintenance of granuloma integrity. Langhans giant cells. Some activated macrophages fuse together to form multinucleated Langhans giant cells characterized by peripheral horseshoe arrangement of nuclei. Although traditionally considered a hallmark of tuberculosis, they are not pathognomonic and may also be observed in sarcoidosis, fungal infections, and other granulomatous disorders. So, presence of Langhans giant cells also never establishes the diagnosis of tuberculosis. CD4 plus T lymphocytes. Outside the macrophage layer lies a dense scarf of CD4 positive Th1 lymphocytes. These are the architects of granuloma formation. By producing interferon gamma, they activate macrophages while TNF alpha helps maintain granuloma architecture. CD8 plus T lymphocytes. They contribute by lysing infected macrophages and producing interferon gamma. They become particularly important during chronic infection. Peripheral fibroblasts and collagen leading to they lie in the outermost layer. They deposit collagen leading to fibrosis and eventual encapsulation of the granuloma. In healed tuberculosis, what happens? These lesions may undergo dystrophic calcification, producing the classic Ghon complex or Ranke complex on imaging. Biological significance restricts bacterial dissemination. The first function of granuloma is containment. Instead of allowing bacilli to spread through blood and lymphatics, the immune system walls them off, creates a hypoxic microenvironment. Granulomas are poorly vascularized. Oxygen tension becomes extremely low. This hypoxic environment slows bacterial metabolism, facilitates bacterial persistence. Ironically, the same hostile environment drives MTB into a metabolically dormant or non replicating persistent state. Therefore, granuloma is simultaneously protective for the host and protective for the bacillus. Dual agent. actually. Now, granuloma is therefore a double-edged sword. Maintains latent tuberculosis infection because bacilli are contained rather than eliminated. The patient enters latent tuberculosis infection or LTBI. Reactivation whenever cell mediated immunity declines, such as HIV infection, diabetes mellitus, anti TNF therapy, prolonged corticosteroid use, chemotherapy, organ transplantation, or aging. The dormant bacilli may resume replication, resulting in reactivation tuberculosis. So, individuals with latent TB infection are clinically asymptomatic, which is very, very bad. Since bacilli remain contained within intact granulomas, there is no cavitary pulmonary disease. These individuals are generally not infectious. Lifelong risk. However, they carry a lifelong risk of reactivation. Approximately 5 to 10% of immunocompetent individuals with untreated LTBI develop active tuberculosis during their lifetime, whereas the annual risk may approach 10% in untreated HIV infection. So remember, latent infection does not imply eradication of the organism. It represents an equilibrium between host immunity and bacterial persistence. This concept becomes particularly important when we discuss drug resistance. Dormant bacilli within hypoxic granulomas exhibit reduced metabolic activity. Since many first-line antitubercular drugs, especially isoniazid, are most effective against actively dividing bacilli. Remember this point. These persister populations are relatively drug tolerant. They are not genetically resistant but phenotypically tolerant. This distinction is fundamental because drug tolerance can facilitate prolonged survival, increasing the opportunity for true genetic resistance mutations to emerge during inadequate therapy. So, to summarize, the granuloma is the central battlefield of tuberculosis. It is an elegant example of the balance between host protection and pathogen survival. It prevents dissemination, establishes latency, and at the same time creates a sanctuary where dormant bacilli can persist for decades. Once immune surveillance declines, these bacilli reactivate and cause active disease. These understanding forms the biological foundation for appreciating persistence, relapse, and ultimately the evolution of drug resistance, which we shall discuss in the next section. So far, we have understood the fascinating biology of Mycobacterium tuberculosis from initial infection, host immune response, granuloma formation, latent infection. The next logical question is if the immune system can contain the organism and we have effective antitubercular drugs, why does tuberculosis remain one of the leading infectious killers worldwide? The answer lies in drug resistance. Drug resistant tuberculosis is not merely a microbiological phenomenon, it is the result of a complex interplay between bacterial genetics, host factors, treatment practices, and public health challenges. In this section, we will discuss how drug resistance develops, different types of resistance, the underlying molecular mechanisms, and why understanding these principles is essential for accurate diagnosis, rational therapy, and effective TB control. We will discuss those in next few episodes. Let us begin with the fundamental concept. What exactly do we mean by drug resistance in Mycobacterium tuberculosis? Before discussing different categories of drug resistant tuberculosis, we must first understand what drug resistance actually means. This is the foundation upon which all subsequent concepts are built. So, what is the definition? Drug resistant tuberculosis or DRTB refers to tuberculosis caused by strains of Mycobacterium tuberculosis that are resistant to one or more antitubercular drugs. The resistance must be demonstrated either by phenotypic drug susceptibility testing or DST, which measures bacterial growth in the presence of drugs, or by molecular methods which detect resistance conferring genetic mutations. So remember, resistance is a characteristic of the bacterium, not the patient. Mechanism of resistance. The most important concept in tuberculosis is that resistance develops through spontaneous chromosomal mutations occurring naturally during bacterial replication. These mutations arise randomly even before the patient receives treatment. Antitubercular drugs do not induce mutations. Instead, they eliminate susceptible bacilli and select the pre existing resistant mutants, allowing them to become the dominant population. Once selected, these mutations are stable and are transmitted to all daughter cells during bacterial replication. Drugs select resistant mutants, they do not create them. Drug resistance in tuberculosis is therefore mutation driven, genetically stable, and heritable. Clinically, it may be primary resistance, where a patient is infected with an already resistant strain, or acquired resistance, which develops during treatment due to inadequate or inappropriate therapy. The consequences are profound. Drug resistant TB is associated with delayed sputum culture conversion, increased risk of treatment failure, prolonged infectivity, greater transmission within the community, and significantly higher morbidity and mortality. This is why early detection of resistance is critical, not only for individual patient management but also for preventing ongoing transmission and preserving the effectiveness of existing anti tubercular drugs. Now that we understand what drug resistance is and how it develops, let us move on to the different types and classifications of drug resistant tuberculosis, which form the basis of current WHO treatment strategies. Now, let's see how drug resistance actually evolves. Initially, the patient is infected with drug susceptible M. tuberculosis. During bacterial replication, spontaneous chromosomal mutations occur naturally. These mutations are random and exist even before treatment begins. If treatment is inadequate because of poor adherence, monotherapy, incorrect dosage, poor quality drugs, treatment interruption, the susceptible bacilli are killed while the resistant mutants survive and multiply. Over time, these resistant bacilli become the dominant population and can then be transmitted to other individuals. Antibiotics do not induce mutation, they simply select pre-existing natural, pre-existing resistant mutants. This is precisely why we always use combination therapy in tuberculosis. It minimizes the chance of selecting resistant mutants. With this basic mechanism in mind, let us now discuss the different types of drug resistant tuberculosis. Before that, this is a very important slide. These three terms are often used interchangeably, but they are fundamentally different. You should know what is drug resistance, drug tolerance, and persistence. Drug resistance is genetic. It results from stable heritable mutations. Even after the drug is withdrawn, the organism remains resistant, leading to treatment failure. This is drug resistant. And tolerance is not due to genetic mutation. The bacteria survive temporary antibiotic exposure because of a transient physiological state. Once the drug is removed, they become susceptible again. Clinically, this causes delayed bacterial killing. And persistence, this is also non-genetic. A very small subpopulation of dormant or metabolically inactive bacilli survives therapy. These persisters regain susceptibility when they start growing again, but they can cause relapse after treatment. So remember one simple rule: resistance is genetic and permanent. Tolerance and persistence are phenotypic and reversible. Let's define these three terms precisely. Drug resistance, a genetically determined, stable, and heritable reduction in susceptibility caused by chromosomal mutations. Drug tolerance, a transient phenotypic state where bacteria survive antibiotic exposure without any genetic mutation. And persistence, a small dormant subpopulation survive therapy and can resume growth once favorable conditions return. The key distinction is simple. Resistance requires a change in the drug regimen, whereas persistence primarily requires adequate duration of effective therapy. Now, here, an important concept is in the evolution of drug resistance is fitness cost. Many resistance mutations initially reduce bacterial growth or virulence. In other words, resistant bacilli may survive antibiotics but are biologically less fit than susceptible strains. Over time, however, compensatory mutations, classically in RPOA or RPOC, in rifampicin resistant strains with RPOB mutations, restore bacterial fitness without losing resistance. So, what is the clinical? What are the clinical importances? This explains why many MDR TB strains are not only drug resistant but also highly transmissible, allowing sustained community spread. So, remember, drug resistance alone is not enough. Bacterial fitness determines whether a resistant strain will successfully spread in the population. Before we proceed further, I would like to mention that the concepts discussed so far are based on current evidence-based references, including the WHO Consolidated Guideline Tuberculosis Guidelines 2025, WHO Operational Handbook, and few other books mentioned here. So, drug resistance is not just about mutations, it's about timely diagnosis, appropriate treatment, and responsible antimicrobial use. Every correct laboratory report and every rational therapeutic decision helps prevent the next case of drug resistant TB. Thank you for your attention. I will be happy to take your questions in the comment section.